Hello, class, and welcome to your Chapter 18 lecture. We have made it. We're at the end. So today we're going to be discussing treating drug dependence. So let's jump in. Our learning objectives for today's lesson are that by the end, you should be able to discuss assessment of addiction severity and readiness to change, list several principles that characterize effective drug treatment, discuss the role of comorbidity in substance abuse and its treatment, discuss pharmacological and behavioral strategies to treating addiction, describe the Mental Health Parity and Addiction Equity Act, as well as discuss screening, brief intervention, and referral to treatment. So let's first touch on treatment of addiction. So when we look at treating addiction, one of the main components is that it must be matched to the individual needs of that person. There is not one method that is going to work for everyone. As we talked about last week, we want to make sure that we are intervening at the earliest stage possible. So for prevention, that was early childhood. For addiction, we just want to catch that person at the earliest stages that they might be in. We should be using least restrictive means to treat addiction. So if the person is just in their early stages, maybe they don't require an inpatient treatment. Maybe they require outpatient treatment. And then we also want to determine the severity of their addiction and their readiness to change when they're entering treatment or considering the type of treatment that may be most effective for them. So looking at assessing addiction severity and readiness to change, we have the Addiction Severity Index, or the ASI, which is a standardized questionnaire used to identify and prioritize problem areas that should be addressed. So it also must take into account Maslow's hierarchy of needs. And it says that if basic needs aren't met, then treatment of substance abuse is not going to be effective. So we're going to look at things such as their medical status, their employment, and what types of support they may have in the community, in their family, looking at what types of alcohol and drug use they're using, legal status, family and social relationships, and psychiatric status. Remember, a lot of co-occurring disorders, mental health disorders, and severe mental health disorders can occur with addiction. So here is Maslow's hierarchy of needs. So basically the ASI is saying that we need to assess all of these different areas, not just their addiction. Because if a person does not have appropriate shelter, food, or sleeping arrangements, we're not going to be able to get them up to the higher hierarchies or higher levels of Maslow's hierarchy here. So they're not going to be able to have a desire to become the best person that they can be. They're not going to have that self-actualization if they're starving, if they don't even get sleep at night. So we need to make sure we're keeping that in mind when we're assessing for their severity of their addiction, as well as how ready they may be to change. So when we look at assessing addiction, we look at behavior change. So this is our behavior change process. So we start at pre-contemplation. So a person in pre-contemplation does not want to change, or they're not considering changing their behavior. So the latter part of that may be because they don't see a need for changing their behavior. Contemplation stage, they get into the contemplation stage, they're now considering changing their addictive behaviors. They're then going to work into the preparation stage. So they're going to be committed to a strategy for changing their behavior. Next, they're going to move into action. So they're actively going to attempt to change that behavior. And then finally, we end with maintenance. So this is a person who has changed their behavior, but to complete the process of change, we need to make sure that that new behavior is part of their lifestyle. So a person is going to go through all of these different stages of change. We then have the screening, brief intervention, and referral to treatment to consider. So evidence-based practices, these are evidence-based practices used to identify, reduce, and prevent problematic use, abuse, as well as dependence on alcohol and other illicit drugs. And they're typically conducted in healthcare settings. So in a screening, a patient is going to be assessed by a healthcare provider for risky substance use behaviors using standardized screening tools. And the goal of these is simply to quickly assess the severity of the substance use and identify the appropriate level of treatment. Do they need outpatient? Do they need inpatient? How severe is that addiction? Brief intervention is then when a patient is demonstrating risky substance abuse behaviors, is engaged by a healthcare provider in a short conversation, and is given feedback and advice. So the focus here is on increasing that person's insight and awareness regarding their substance use and their motivation toward changing their behaviors. And then we may have a referral to treatment. So a referral to treatment is going to be when a patient is referred to brief therapy or additional treatment as deemed appropriate by their screening and assessment tools. So by using all of these, we can reduce healthcare costs, reduce trauma, and the severity of drug and alcohol abuse. So when we look at treatment, there are a few principles to keep in mind. We need to use a wide variety of approaches. So things including counseling, psychotherapy, cognitive therapy, and different treatment methods. Those that are most successful are going to combine therapies with other services. So with that, I mean that you want to combine drug abuse treatment programs with other types of therapies and other types of services. So again, say it's mental health services. Say they need parenting classes. Could be something like that. Indirect problems must also be addressed. So we need to address that bottom level of Maslow's hierarchy of needs. Do they have proper housing? Do they have legal issues? Do they need a visa? Do they have financial issues or a lack of family or childcare services? Because if a person doesn't have childcare services, they may not then engage in treatment because they don't have someone to watch their children while they're doing that. Often, more than one exposure to treatment is going to be required. Typically, people don't stop abusing drugs with their first dose of treatment. When we look at the effective duration of treatment, typically under 90 days is going to be ineffective. When we look at methadone specifically, it typically takes a minimum of 12 months for it to be effective, whereas those addicted to opiates, treatment may need to go on for several years to keep them abstaining from use. A treatment's effectiveness should be measured through multiple individual factors. So how effective a treatment is, if we think back to drug courts from last chapter, it's not simply looking at did the person stop using or reduce their use, it's how is their family functioning? Are they employed? Has their criminal behavior decreased? Have they improved some medical conditions they may have had? Maybe they had poor liver function because they were drinking alcohol in excess. So we want to look at other factors that have also been improved on by the person obtaining treatment. Also, age and gender-related considerations must be made. So women and females have higher rates of sexual or physical trauma, as well as PTSD, that you're going to want to treat with those other services that's combined with the substance use treatment. There's also issues for women typically around financial independence, pregnancy, and then the childcare example I gave earlier. So when we talk about gender, we're specifically talking about biological, social, and environmental factors that are related to a person's gender. And then that criminal justice involved substance abusers may have unique needs. So those involved in our CJ system, if they're in jails or prisons, they may lack various options for treatment. So remember we said that one type of treatment does not fit all, and it needs to be individualized. That may not be the case for these CJ involved abusers. Or there may not be treatment available at all. There may be a wait list for treatment. They may not be able to get into the program because they're getting into physical altercations while they're in the jail, so they're in solitary, for example. So we need to make sure that we are addressing the unique needs of this special population. And then there's 3 different factors that drive a person's retention in treatment. So the first is going to be an individual's motivation to change their drug using behavior. The second is the degree of support that they have from their family and their friends. And the third is pressure that they may have from employers, the criminal justice system, or other extensions of the court to remain in treatment and be successful. So looking at the National Institute on Drug Abuse, there are 13 principles for effective addiction treatment. We're just going to run through these quickly. So the first is that addiction is a complex, as we've been learning all semester, but treatable disease that affects not only your brain function, so your cognition, but also the person's behavior. So again, treatment, we want to make sure that we're addressing not only the cognition, but also their behavior. There is no single treatment that is going to be appropriate for all individuals. Treatment must be readily available for the person to engage in when they're at the proper behavior change stage, when they're in contemplation, when they're ready for action. Effective treatment is also going to attend to multiple needs of the individual. Remember Maslow's hierarchy of needs? We're going to address their housing. We're going to address their food insecurities. Remaining in treatment for an adequate period is going to be critical for the effectiveness of that treatment. Remember, for methadone, it should be a minimum of 12 months, whereas opiate addiction may need to be for several years. Behavioral therapies are going to be the most commonly used form of drug abuse treatment. Again, it's all about behavior change. And medications are an important element of treatment for some patients. So again, some patients may not be able to just simply stop using. We may need to look at methadone maintenance, for example. Treatment and service plans must be assessed continually and modified as necessary to ensure that it's meeting the patient's changing needs. So maybe this month I have issues with housing. We Get Me housing. Okay, so now the next 2 months when I come back, we need to make sure that I still have housing, but maybe now my issue is that I lost my job and I need to now find a new job. So make sure that we're assessing the patient continually and addressing those needs as they arise. Understanding that many drug addicted individuals also have other mental health disorders that should be addressed. That medically assisted detoxification is going to be just the first stage of addiction treatment. And by itself, it's not going to do a lot to change long-term drug use. So when we're talking about detoxification, such as the first stage in the process of drug courts is detoxing the offender from that substance. When it's done medically assisted, it's simply cleansing the body of that drug. It's not going to change those behaviors and those cognitions. Treatment also does not need to be voluntary to be effective, but we eventually want to get that person into a stage of behavior change where they do want to change. Drug use during treatment must be monitored continuously because lapses during treatment do occur. So making sure that we are still giving drug tests, that we're still taking those and reviewing them and making sure that they haven't started using again, or maybe simply replace that drug with a new one. And finally, treatment programs should test patients for the presence of HIV and AIDS, hepatitis, and other infectious diseases, as well as provide targeted risk reduction counseling and linking patients to treatment if necessary. So remember, we're addressing all of the needs of the individual, not simply looking at the substance abuse issue. Now, when we look at comorbidity, when we're talking about treatment, comorbidity is when there are 2 or more illnesses occurring in the same person. So anxiety, psychosis, depression, and ADHD are common among those with substance use disorders. And the brain regions that are affected by drug addiction also typically occurs in other mental health disorders. There are overlapping factors, such as creating a causal relationship that's difficult to establish. So these overlapping factors can be genetic vulnerabilities, trauma, stress, even underlying brain abnormalities that are going to contribute to both substance use disorders as well as mental illness. So it may not be easy to tell which came first, the chicken or the egg, which came first, the mental health disorder or the drug addiction. An effective treatment is going to require an accurate diagnosis of both of these conditions. So a person should be screened for a mental health disorder during substance abuse screening and vice versa. So some of the barriers to addressing comorbidity in individuals is that primary care facilities are the primary treater of mental health disorders. Substance abuse treatment, however, is a mix of professionals, so they may not be talking with one another. Neither of these, though, can fully address the range of both conditions. So your primary care is not going to be able to fully address your mental health disorder and your substance abuse disorder. These two need to communicate and make sure that they're getting you into the proper treatments. There's also a bias against using pharmacological interventions at some substance abuse treatment facilities. They don't want to bring in those medications. So there may be a lack of qualified staff, for example, to do that medication management. So they just don't want to bring it in at all. They also don't want to just replace one addiction for another. And there's also, again, a lack of treatment in CJ settings, and we know that CJ involved individuals typically have one or more of these disorders that they present with. So overall, looking at drug addiction treatment specifically in the United States, the various reasons for not receiving treatment include a lack of health coverage or an inability to afford the cost, which was number one, a lack of readiness to stop using the drugs, negative effects that it may have on their job. So I can't engage in treatment because I can't miss work for that. Having a lack of transportation to actually get to the treatment, or it simply being an inconvenience. And other individuals reported just not simply knowing where to go for the treatment. So for every $1 that we invest into addiction treatment, it actually equates to a $4 to $7 reduction in drug-related crime, theft, and CJ costs. So it pays to invest in drug and addiction treatment, whether we like it or not. Some people say, well, why are we providing this type of treatment? You know, the person brought this on themselves, maybe their own addiction. But you see here how drug addiction and the whole class is substance abuse and crime. The goal here is to reduce crime, is it not? To reduce societal costs and to improve the lives of those we're serving. There's also personal and societal benefits. So those fewer interpersonal conflicts, improved workplace productivity, and even reduced drug-related incidents. So the Mental Health Parity and Addiction Equity Act of 2008 actually requires that health insurers and group health plans provide the same level of benefits for mental health or substance abuse treatment and services that the insurer provides for medical and surgical care. So it has to be at the same level. And factors such as copays and the number of visits that are paid for by the insurance company must be comparable. So this act is basically saying that we're acknowledging that medical and surgical care is as important as mental health and substance abuse treatment. So we need to make sure that we're treating individuals' mental health properly and substance abuse properly, because guess what? You're going to then save money on the back end of that in medical and surgical care costs. And finally, that the prior authorization that is sometimes needed for medical care must also be comparable or less restrictive than it is for those physical health services. So what are some historical approaches that we've taken to drug treatment? Well, we have first Alcoholics Anonymous, which began in the United States in the mid-1930s and is actually now an international program. This believes in a greater power, and admitting that that person has no power over the drug, they may also be asked to make amends as part of their 12-step process to those that they've harmed. You can have either closed or open meetings. So open meetings are going to be those who are open to, I said open, right? Opener to anyone who has an interest in attending or simply maybe witnessing the meetings and learning more about what happens there. While closed meetings are for alcoholics who have a serious desire to completely stop drinking. A branch off of AA is Al-Anon, which is specifically for spouses and close relatives of alcoholics. and then Alateen, which is for teenagers who have had their lives affected by someone else's alcoholism. We also have the approach of rehabilitation programs. So, for example, the Alcoholics Anonymous founder, Bill W., actually allowed alcoholics to stop drinking or dry out in his home. So we had these drying out houses from about the 1940s to the 1950s. The Minnesota model is from the 1950s, and it has an AA philosophy, but it includes a multidisciplinary treatment team. Unfortunately, because of insurance issues, these only were able to last for about 30 days, the actual program, which we know treatment generally isn't effective if it lasts for less than 90 days. So they did not last. So some of the general therapeutic strategies that we use today are things such as medical detoxification. So this is a safe way of managing the acute physical symptoms of withdrawal that are associated with stopping drug use, specifically under the care of a physician. So, for example, untreated withdrawal from alcohol and barbiturates can be fatal if that user's use is at a certain threshold. It will not cause long-lasting behavior change, as we previously said. So it's more of a precursor to treatment than an actual mode of treatment. We have short-term residential treatment programs, which are 3 to 6 week hospital-based inpatient treatments. So this is typically followed by an extended outpatient therapy session and the person participating in either self-help groups such as Alcoholics Anonymous. We then have long-term residential treatment, which are about 6 to 12-month inpatient treatment programs in therapeutic community settings, which we've previously talked about. These programs are going to be highly structured and offer 24-hour care. These are going to focus on re-socializing the individual, developing their personal accountability and responsibility, as well as employment training. And then we have outpatient treatment, which is for those who have extensive family and community support or who are maybe employed. So remember, we want to make sure that the program and treatment we put them in is individualized and meeting their needs. So if a person says, I must stay employed, say, I'm married, my husband is very supportive, I have a supportive parents who are still there, and I have a community that is also supportive of me. I don't maybe need to go to an inpatient treatment setting. I can get that outpatient while keeping my job and staying within the home. There's a few behavioral therapies that we also use. The first one being cognitive behavioral therapy, or CBT. So this is based on a theory that learning patterns play a critical role in the development of maladaptive behavior patterns such as substance abuse. So in CBT, we're going to help the individual to develop effective coping strategies and explore the positive and negative consequences of their drug use. In contingency management interventions and motivational incentives, this is going to be a reward value increase with evidence of sustained abstinence, but it'll reset to the lowest with a drug relapse. So it's giving tangible rewards to a person to reinforce the positive behavior of stopping drug use. We then have community reinforcement approach plus vouchers. So this is a 24-week outpatient therapy specific for alcohol and cocaine addicts. So here they're going to utilize recreational, familial, social, vocational, and material incentives to show that a lifestyle without drug use is actually more rewarding than one with drug use. So you just want to show that person that, look, when I'm not using drugs, I have all these positive things happening in my life, and I don't need to use the drugs anymore because my life is better without them. We then have MET, or motivational enhancement therapy. So here we're going to use motivational interviewing. So getting the person to elicit change talk out of them. We want to hear them say what they want to change, asking open-ended questions to learn more. And initial assessments, they consist of initial assessments plus 2 to 4 individual sessions. So we're going to evoke that motivated change to resolve them being ambivalent about going to treatment or stopping their drug use. So this is maybe just a first step in the therapeutic process. We then have the matrix model. So here, patients are going to learn about issues that are critical to addiction and relapse, and they're going to include elements of relapse prevention, family and group therapies, drug education, as well as self-help participation. So here the therapist is going to foster positive and an encouraging relationship with the patient that will reinforce positive behavior change. And then finally, we have family behavioral therapy. So this is for co-occurring problems such as conduct disorders, child mistreatment, maybe depression or family conflict, unemployment. So this is family-based, so it's going to involve the patient plus one significant other in their life. And finally, we're going to talk about pharmacological strategies. So I know we've gone over these briefly in past chapters, so we're just going to briefly go over them now again. So we have methadone. So methadone specifically prevents opiate withdrawal and decreases cravings. This is conducted in specialized outpatient settings, and it is administered orally for a sustained period at a dosage that is going to be sufficient to prevent opiate withdrawal, but also decrease that person's cravings. People on methadone can hold jobs and avoid crime and violence. They can reduce their exposure to HIV, and they're also engaging more readily in counseling and behavioral interventions because they're not constantly thinking about the craving that they have. They're not going through the effects of withdrawal. We then have naloxone and naltrexone, which simply suppress the action of a drug. These are conducted in outpatient medical settings, and the person must be opioid free for a few days before they take naltrexone specifically, to avoid withdrawal symptoms. And similar to methadone, it's going to be taken orally for a sustained period of time to prevent the effects of self-administered opioids. So it doesn't allow the person to feel the effects when they do take that drug. However, patient noncompliance is frequently an issue with these. So they're most appropriate for those individuals who are highly motivated or recently detoxed. So those such as professionals, parolees, and probationers who are motivated to change. Buprenorphine. So this is going to reduce or eliminate the withdrawal symptoms of opiate dependence. So it's a partial agonist at the opioid receptors, but it generally is not going to produce that euphoria or sedation feeling. Nicotine replacement therapy simply is going to relieve the withdrawal symptoms one may experience from nicotine. Disulfiram is going to cause nausea, vomiting, flushing, and anxiety if a person consumes alcohol. So this one is to help a person get off of alcohol. And acamprostate. So this is going to treat symptoms of alcohol withdrawal by reducing the associated symptoms. So it's going to reduce anxiety, insomnia, maybe feelings of restlessness or dysphoria. So it's treating those symptoms that a person is going to experience when they're withdrawing from alcohol. So, in sum, the ASI is an assessment tool that is used to identify and prioritize critical problem domains that require immediate attention. Assessing a person's readiness to change abuse behavior is important in helping to select the best treatment plan and address that client's needs. The most effective drug treatment programs are going to combine therapy with other services, address those indirect problems, are for an appropriate duration of time, and they're going to consider age as well as gender factors. Comorbidity is a condition in which there are two or more illnesses occurring in the same person. This can be substance abuse and mental health, for example. So there are overlapping factors that can contribute to both. Therefore, effective treatment requires an accurate diagnosis of both the substance use disorder and the mental health disorder to treat it appropriately. Pharmacological strategies are going to be based on the properties of the drug to which the person is addicted, while behavioral strategies or focusing on changing the individual's behavior and thinking patterns. The Mental Health Parity and Addiction Equity Act requires that health insurers and group health plans provide the same level of benefits for mental health and substance use treatment that it does for medical and surgical care. And finally, the SBIRT is an evidence-based practice conducted in a healthcare setting that is used to identify, reduce, and prevent problematic drug use, abuse, and dependence on alcohol and illicit drugs. So that was your Chapter 8 lecture on drug treatment programs. I hope everyone has a fabulous last week, end of the semester, and as always, if there's any questions, just reach out.